Hello, everybody. At the outset, let me wish all of you a happy Children's Day. I am Dr. Vandana Dhamankar, representing the Indian Cancer Society, which is a proud member of Beat Cervical Cancer Network of India. It's my honor to welcome you all to this webinar on HPV vaccination on behalf of BCC Network, led by Cancer Foundation of India, India Research Center, Harvard School of Public Health, Healthy India Alliance, Prevent Global HPV Cancers Program of American Cancer Society, and Cancer Research UK. So welcome to one and all. Cervical cancer, as we all know, cervical cancer often impacts women in the prime of their lives, majorly mothers who are raising children, caring for families, and contributing in every way that they can. Today, as we delve into the facts and strategies around cervical cancer prevention, let's remember 4 important points. First, cervical cancer is preventable and curable. Yes, this is the one cancer which can be prevented. Second, cervical cancer is a global health issue. The incidence and mortality are higher in the lower and middle income countries, but it is a global health issue. Third most important point, eliminating cervical cancer is possible. And fourth, collaboration is essential. Ending cervical cancer requires a global commitment and collaboration with stakeholders across sectors, policymakers, healthcare providers, civil societies, research community, education sectors, and the private sector. Most importantly, the patient advocates. The recent Quad Moonshot initiative, launched by our Prime Minister, exemplifies the power of collaboration in this mission. The BCC network is a collaboration of NGOs across India dedicated to eliminating cervical cancer, particularly through HPV vaccination and screening. This network unites both cancer and non-cancer NGOs in India, most importantly, promoting consistent and evidence-based messaging to enhance the HPV vaccination rollout. We all know the government commitment, and BCC is here to strengthen the efforts of the government and all other stakeholders. We all agree that India's vast diversity presents a lot of challenges, with millions of girls to vaccinate and women to screen, especially in rural areas. However, we do have the tools and the knowledge to prevent this disease. With access to an indigenous vaccine, our mission is even more attainable. I sincerely urge you to participate very actively in this webinar. All your queries can be answered by the expert panelists. We are very thankful to have them. There are so many myths around cancer and the vaccine. We all can clear our queries today. I'm truly honored to set the stage for today's webinar on 4th WHO Day of Action for Elimination of Cervical Cancer. We all know that the actual date is 17 November. However, we are doing it today with an intention to offer it as Children's Day gift to all our daughters. We indeed are thankful for the WHO headquarters participation through Dr. Vinod Bura. May I now invite Dr. Vinod Bura, who's Coordinator, Immunization and Vaccine Development, WHO Southeast Asia Regional Office. Dr. Vinod Bura, please. Thank you.
A very good afternoon and good evening to everyone. And once again, big thanks to the organizer for inviting us and to be part of the important discussions. I would like to share my screen and so can someone confirm if the screen is visible?
Yes, sir.
It is.
Just
okay.
Screen.
Yeah, thank you very much. So what I would like to do in next couple of minutes, 5 to 7 minutes, is just to take you quickly on the overview of the implementation of HPV vaccine introduction. How many countries have introduced? What are the challenges, specifically in Southeast Asia region? So, colleagues, all you are aware of this 2030 global target to see a world without cervical cancer. So there are 3 major pillars in that. That is 90% of the girls, the adolescent girls should be fully vaccinated. 70% of women should be screened with a high precision test at 30 in the age group of 35 to 45 years, and 90% of women identified with cervical disease should receive treatment and care. So those are the three pillars, and this is part of the SDG 2030 target, and we aim to have a 30% reduction in mortality from cervical cancer. So with this view in background, at this point of time, as we are talking, 143 countries worldwide, member states, as we call in WHO language, have introduced HPV vaccination as part of their routine immunization services, which they are providing to girls in the age group of 9 to 14 years. In last year itself, there were 13 new countries which introduced vaccines in this post-COVID era. So the introduction speed is there, but some of the big countries still have not introduced vaccines. Looking at Southeast Asia region, you all are aware of the cancer burden in Southeast Asia. We have 195,000 new cases of cervical cancer seen in the females in the region, and very sadly, 118,000 deaths seen due to cervical cancer in the region. So SAGE, which is the WHO's global advisory group, the independent advisory group, has recommended that countries can now opt for a single dose of HPV vaccination, primarily targeting girls in the age group of 9 to 14 years. The initial recommendation was for 2 doses for all ages starting from 9 years. However, with new evidence that has come up, with new scientific evidence that has come, there is now an option for countries to switch to a single dose of HPV in the age range of 9 to 20 years old. Again, there are different recommendations for other priority groups, and for immunocompromised, and also for secondary targets, which are boys and other adolescent women. However, given the global constraint on the vaccine supply, our recommendation is still to target the adolescent girls globally. In Southeast Asia region, that we have 11 member states, 8 countries have introduced HPV as part of their national routine immunization. We have 7 countries where there has been a nationwide introduction, and there are different schedules that are being followed. Bhutan, Indonesia, Sri Lanka has a 2-dose schedule, and a 1-dose schedule is now introduced in Maldives, Myanmar, Thailand, Timor-Leste. Thailand is currently revising its schedule from 2-dose to 1-dose. We are in discussion and advocacy for other countries to go for a single dose introduction. There are 2 subnational introductions. Bangladesh has introduced in the urban areas, and as we speak, they are scaling up the vaccination in the remaining 7 provinces of the state of the country. India has introduced in Sikkim states, and there are plans for introduction in 2 other countries, that is India and Nepal. In fact, Nepal's introduction has already been approved, and we are hoping that in early 25 they will have a nationwide introduction. These are some of the coverages that you can see. There's still uneven inequities in coverages out here. You can see both Sri Lanka and Thailand had a drop in coverages, primarily because of procurement challenges that we saw in the COVID era. But however, Bhutan has sustained very high coverages along with Sri Lanka that we see. Just wanted to give you this glimpse on when we talk about immunization, we talk about the breadth of protection through vaccination. And amongst all vaccines, HPV is still one of the major concerns for us in terms of introduction. We've seen scale up in hepatitis vaccines, in IPV, in pneumococcal vaccines, even Rota vaccine, we are seeing a rapid scale up. However, our concerns are still on HPV vaccine, and the region still needs to do better to improve the coverage. Some of the challenges that we see, as I mentioned, there were some supply related issues. Again, the cost of the vaccine is still pretty high. Affordability and sustainability of HPV is a challenge. The delivery strategies are varied. School health programs are not uniformly established in many member states, and reaching girls who are out of school is quite a challenging area, and still not a very clear strategy or a micro planning. How do you reach them? Again, decision for introduction in some countries it's a costly vaccine, and the financial constraints are there in terms of introduction. And again, the issue on the logistic and access, especially in a country like DPRK and Myanmar, is a constraint and challenge. However, we saw that in 2024 there is a progress in quite a few states. However, there has been delays in introduction in at least two big countries. So what is the plan out here currently? As we speak, Myanmar, Thailand, and they all are organizing catch-up campaigns to vaccinate girls who were dropped, who were left out because of COVID and other disruptions. Bangladesh is accelerating its expansion in the 7 provinces, and India has announced the introduction. However, details are awaited in terms of their rollout plans. What we see is more advocacy is needed for the adoption of single dose, and advocacy to develop and strengthen school health program as a solid platform to reach out to girls is what is needed out here. So with that, I'd say thank you, and together we can end cervical cancer. Thanks a lot.
Thank you so much, Dr. Bura, for joining us and for giving us the insightful talk. With that, now I invite Ms. Mridu Gupta, CEO of Capid India and founder member of BCC Network, to introduce the speakers and guide us through the proceedings. Hello, Mridu.
Hi, thank you, Dr. Vandana. Thank you, Dr. Pura. And incidentally, Dr. Vandana, who's director of Indian Cancer Society, and Indian Cancer Society is also a founding member of BCC. So we are here representing BCC, and we have a very impressive lineup of speakers coming on. So we will very quickly jump into the panel discussion. But before that, just a couple of points for all of you. If you have any questions, please put them in the question and answer box. It'll be very difficult for us to pick out the questions from the chat box. Put them into the question and answer box. If you want a particular panelist to respond to your question, please name the panelist and then put the question in. And if it is a general question, please put it in and we will have it answered. Right? If there is a technical glitch, if a Wi-Fi or somebody drops off, please wait. We will come back online. And with that, we will get started. And I would like to invite to begin this panel discussion, Dr. Devasena Anantharaman. She is from RGCB, Thiruvananthapuram, and one of the principal investigators of the IARC-WHO study. She will speak about the result of the 15-year study of the HPV vaccine in India on efficacy. Dr. Devasena.
Yes. Good evening, good afternoon, and good morning to all of you, depending on which part of the world that you're joining in from. I hope you can see my slides. So without much ado, I will jump right into it. So thank you, Mridu, for that very kind introduction. And I would also like to thank the organizers for this opportunity to speak to you today about the data that we have in the IARC Indian study. So since we've already done the introductions on cervical cancer, its burden, the need for vaccination, I'm not going to go into any of those, and I'll jump right into the topic that's been assigned to me and share with you the data that we've generated in the IARC India study. So this study was initiated in 2009. And it was initiated as a randomized controlled trial to look at 2-dose HPV vaccination versus 3 doses of HPV vaccination. But specifically, the overarching idea was to develop nation-specific data on the efficacy, feasibility, safety, and acceptability of the HPV vaccine. So the study had identified 9 recruitment centers, distinct geographic regions in the country with 188 clusters. And the primary endpoints that were defined were the immunogenicity endpoints and the infection endpoints. And the secondary endpoints were long-term clinical outcomes with the occurrence of cervical intraepithelial neoplasia or invasive cancers. So just to put a little handle around it, so we know that antibodies are established surrogates of vaccine-induced protection. So robust antibodies that are generated post-vaccination would imply that we will see very low or negligible infections against the targeted types covered by the vaccine. And that would mean that the absence of persistent infections would translate to reduced cervical intraepithelial neoplasias in that same cohort. So we examine each of these endpoints. For infection endpoints, we look at broad spectrum HPV genotyping assays, which are highly sensitive and highly specific. And for the screening endpoints, we look at hybrid capture or COVAX-based clinically relevant tools for detection of HPV infection, and in some cases, type-specific infection. So the study, as I told you, started as a randomized controlled trial involving 20,000 girls, and they were to be randomized into two groups: those receiving 2 doses or those receiving 3 doses, and 10,000 girls in each arm. But in 2008, there was a suspension of the HPV vaccination in all trials in India. And that led to a disruption of the vaccine trial recruitment. So we ended up with girls who had the 2 doses as per design, as well as two default groups, that is groups with girls who had extended last dose, whether it was the 3rd dose or the 2nd dose, and girls who received either a single dose and were intended for 2 doses, or girls who received only 2 doses instead of 3 doses. So where did that leave us? So we went then from being a randomized controlled trial to now an observational study. And you can see here that we had the 2 recommended dose groups, but we also had the default groups. But the beauty of this study has been in the way that the recruitment has happened, and 95% of the recruitment happened prior to the ban that was introduced in 2010. So you can see here, as evidenced by the numbers, that they're very comparable across these different groups. So that's tremendous work from our recruiting centers, each one of them. And because we now became an observational study, there was a need to have a comparator group. So we had an unvaccinated cohort to compare against the infection endpoints, that is the incident and the persistent infection endpoints. And we had a separate second round of unvaccinated cohort to compare against the screening cohort. So what we did with these 20,000 girls is that they underwent yearly follow-up and repeat sampling at every visit for blood that went into the antibody measurements right up to the 15th year endpoint, which we are running on now, and the study is still active, and cervical cancer, and cervical specimen collection for detection of incident and persistent infections type specifically using a high throughput platform when girls became eligible. And eligibility was defined as 18 months after marriage or 6 months after first pregnancy. Every girl contributed at least 4 consecutive samples. So that's a great wealth of data that we have in the biorepository. And the screening was done using hybrid capture 2 or COBAS, which are the validated tests. And in some instances, when they were positive, type-specific HPV genotyping was also done. All the girls who were screened positive underwent a colposcopy, and there was a referral for all of them. So given the wealth of the data that is available in this study and the very large biorepository that we've had, and the ability to be able to run high throughput assays on this of international standards, this study has really contributed significantly in shaping policy on HPV vaccination. So what I'm showing you here is the data on the 2-dose HPV vaccination. So you might remember me mentioning that at the time that the study started, the primary aim was to compare 2 doses versus 3 doses. And the standard recommendation at the time was to have 3 doses of HPV vaccine. And what we tried to do in our analysis here is to compare girls who were older, that is 15 years or older, and had received 2 doses of the HPV vaccine, and check whether the antibody and the infection endpoints were similar to those who received 3 doses in that same age group, and in the age group of the younger girls. So the rationale here and the recommendation behind having 3 doses for older girls was based on the premise that antibody responses wane with age. So older girls would require larger, greater number of doses to attain the same degree of protection. But what we saw across the different endpoints that we measured was whether it was through the antibody response. 15-year-old girls who received the HPV vaccine in 2 doses were non-inferior to the same age girls who received 3 3 doses, or even younger girls who received 3 doses. And this was the same trend we saw with persistent infections, and we know that persistent infections are a surrogate for vaccine efficacy in terms of cervical intraepithelial neoplasias. And in early screening endpoints, where we had about 400 women tested, and about 17 of them turned out to be screen positive, none of them were associated with the types covered by the vaccine. So very robust protection among older girls who received only 2 doses of the vaccine. So this has great impact for programmatic implementation of HPV vaccination at the time. But what we really think is the greatest impact of our study comes from the single dose that I showed you about right at the start. So we've been publishing on this routinely since the inception of this study, showing single dose HPV vaccination generates robust antibody responses, has lower infection endpoints. But what I'm showing you are data here from 2 very important time points in the follow-up of the study. So the first study is after 10 years of follow-up, and you can see that the number of girls who've received the single dose vaccine are about 2,000, and there's only been 1 case of HPV 16 or 18 persistent infection in them. This translates to a near negligible proportion of HPV positivity in that group, and a vaccine efficacy of about 95% in that cohort. And this vaccine efficacy of 95% in the single dose is very similar to what we see, in fact, non-inferior, comparable, or identical, whatever term you might want to choose, to that in the 2 dose and to that in the 3 doses. Now, we followed up these results, and we now have right off the oven 15-year immunogenicity data that's been in the public domain, and this paper has come into print just a few days ago. So here again, at the 15-year time point, you see we've accrued more girls who are eligible to be tested for HPV genotyping. And you see very, very reassuringly that the proportion of HPV 16 or 18 positives are negligible. There were no HPV 16 or 18 positive cases here. And how that translated to vaccine efficacy is greater than 90%, between 92 to 95%. So very, very, very strong evidence that single-dose HPV vaccination is protective against persistent HPV infections. So this data has been taken up by the WHO, and as we heard earlier from Dr. Bura, the SAGE recommendation on single-dose HPV vaccine heavily relies on the data that came from our study. So subsequent to these findings, the IARC evidence summary was released in 2022, following the first impactful single-dose publication, and very strong recommendations were made in this summary brief. The first was a call out to policymakers to introduce HPV vaccination with at least a single dose. So this was the onset of the off-label single-dose HPV vaccination. And the second was to vaccine manufacturers to ensure equity and supply of the HPV vaccines, particularly in LMICs. And I think this box has been ticked as well with the arrival of Cervavac, which is from the Serum Institute of India. And the third was to immunization program managers to assess strategies to improve vaccine coverage and the use of single-dose schedules. So where we stand today is a strong recommendation of a single-dose HPV vaccination to girls under the age of 20, whether they're in the earlier age groups or in the older age groups of 15 to 20, and 3 doses for those who are much later, primarily because we think that they may be potentially exposed to HPVs, and to 3 doses in the immune compromised individuals. So I think I will stop here. I have several people to thank for this work, and you can see this is the investigator network of this study. It's a very concerted effort, and the team has done an absolutely brilliant job in following up these girls and keeping them in the study over this 15-year period of time. And I would just end with saying the IARC India multi-center study is really a flagship program, in that it's the only study where we have women of these numbers that are eligible for screening, from where real life data on the efficacy of cervical intraepithelial neoplasia following HPV vaccination can be gleaned. And it's really we're really proud that that data is driven from India. So thank you all for your patient listening, and we'll be very happy to take on any questions. And I also have one of our colleagues, Dr. Smita Joshi, in the panel. She's a part of the study as well, so I'm happy she's here too. Thank you.
Thank you, Dr. Devasena. Thank you so much. And this is definitely very strong evidence on efficacy of the vaccine. Wonderful. So as we move forward on India prepares for the successful rollout of the HPV vaccine, I would like to invite Ms. Emily Kobayashi. She's the head of the HPV vaccine program, GAVI, the Vaccine Alliance. And Ms. Emily is going to talk about what GAVI plans for India. Right, ma'am? Over to you.
Yes, thank you very much. And thank you for the opportunity to join this meeting. It's a wonderful opportunity to begin the preparations for the cervical cancer vaccine or continue the preparations. And it's wonderful to see such a diverse group of participants. So for those of you that may not have come in contact or be aware of GAVI, GAVI is a global health donor that helps to vaccinate over half of the world's children. In 2022, the GAVI board approved an initiative to increase access to the HPV vaccine worldwide. And we do this through support to the purchase of vaccines, supporting national governments with the costs of introduction of the vaccine and scale up of the vaccine, and through technical assistance and learning support. And the overall value of this initiative was estimated at $600 million. And it has a global goal of reaching 86 million girls with the HPV vaccine by the end of 2025. And we're very hopeful that the initiative in India would contribute to that global goal. GAVI has an ongoing strategic partnership with the government of India to strengthen access to immunization, including the HPV vaccine. In December of 2021, the GAVI board approved the renewal of GAVI's strategic partnership for another 5 years up to 2026 for a total amount of $250 million. And this strategic partnership focuses on health system strengthening, reducing the number of children who have never received a vaccine, and supporting the introduction of both the HPV vaccine and the typhoid conjugate vaccine. So through GAVI support, India is expected to receive around 26 million doses of the Merck Gardasil 4 vaccine. These will be fully financed by GAVI, and we anticipate that they will begin to arrive around the second half of 2025. As with all GAVI support to India and our investments in India, this will be done in partnership with government and will be complementary to domestically procured doses. I should also mention that GAVI is providing financial support to some in-country technical partners in India to facilitate this introduction and to help the stakeholders in India to adapt global lessons learned to the specific needs and the context of India. So I just wanted to take my last 2 minutes just to share a bit. Over 140 countries around the world have introduced the HPV vaccine. Over 40 of those have done that with GAVI support. And from these introductions in many places, there are very key considerations for the introduction of the HPV vaccine in India that I wanted to bring to the conversation today. And I think it all starts with understanding what is special about the HPV vaccine. First, that it's a vaccine against cancer, and in many cases, the first that people would have heard of a vaccine preventing cancer. Secondly, that it targets girls only as the priority group, and sometimes that raises questions and requires careful messaging so that stakeholders can understand why those girls are being prioritized. And then lastly is the fact that it reaches an older age of children. So we're targeting girls perhaps in the range of age 9 to age 14. And these girls may not have the same touch points with the health system that younger children or infants would have through the routine EPI program. So as a result of these special characteristics, we need communications and a delivery strategy that are adapted to the specific characteristics of the vaccine. Something else that we've seen from many countries is the importance of partnerships, and these partnerships need to extend beyond the immunization community to the cancer community that I see is represented so well here today. We also need to include women's health advocates who know how to communicate about the risk of cancer, about the realities of cervical cancer, and make the health threat real. What we've seen is that when you communicate about cancer, when you raise the awareness and profile of cancer, the risk of cancer becomes much more imminent to the people making decisions about vaccinating their daughters, and it makes them much more open to accepting the vaccination. Thirdly, we have the opportunity to learn from initiatives that have already begun at the subnational level in India. Perhaps there are things that have already gone well. There are strategies for reaching girls where we've seen we can reach more girls. There are communications approaches that have been validated or tested in different Indian contexts, and we should take the opportunity to learn from those and scale them up nationally. And then two more things. So one is that the one thing we've seen that's the most dangerous for an HPV introduction is if rumors emerge that are uncontrolled and not effectively responded to. In many countries, high-income countries, middle-income countries, and low-income countries that have had unsuccessful introductions of the HPV vaccine, this has been the reason, because of rumors or misinformation. So that means that we should expect those rumors and misinformation to emerge as we move closer to when the vaccine is introduced. We should be prepared to pick those up wherever they may be circulating in social media, in the community, in the media, and have a wide group of communicators who are equipped to respond to those rumors and help to allay concerns that people may have. And then finally, it may feel far off, but the vaccine is going to be introduced in the context of a campaign. But if we're actually going to reap the benefits of this vaccine, it's going to take sustained immunization year after year, reaching 9-year-old girls wherever they are. And we have to do that work in order to build up a protected cohort and really benefit from the population level immunity that this vaccine can provide and has been seen to provide in countries that are immunizing for a longer period of time. So we need to be thinking, even as we're preparing for a campaign and a successful introduction at a large scale, what will this look like the year after for that next group of girls that have achieved their 9th birthday? How will we be reaching them year after year to achieve the benefits of the vaccine? So thank you very much for the opportunity to participate, and looking forward to the Q&A.
Thank you, Emily. Some wonderful points that you've raised there. There are so many questions in the chat where people want to know when is the vaccine being rolled out. So it was very heartening to hear your comments on that. And about communication, yes, that's something that the BCC has been speaking about. I mean, it was when we started it, that was the prime reason that we wanted to be there. So we get the communication right, because we've seen how it can go so wrong also. And so thank you for your points. And just the right person to speak about the healthcare communication, I'd like to call Dr. Viswanath, Professor of Health Communication, Harvard University. So we have the right segue into your conversation now.
Great.
And please, if you could enlighten us.
Well, thank you so much. First, let me thank the organizers for having me on the panel. It's been great listening to the talks, and it's fairly clear, from the speakers who gave the preceding talks, that we are in a very exciting time, where we can actually have an opportunity to eliminate the dangers of cervical cancers. And the evidence is pretty unequivocal, the safety and efficacy of this vaccine, as we have just heard. Then the question is, how is it and why is it that we are not able to, vaccinate or get it accepted as much as we should? So there are structural barriers that have been highlighted in terms of access, in terms of introduction, the policies, etc. But what I'm going to talk about, and as has been alluded by the prior speaker, the communication challenges. And this is what we focus on in our lab, where how do you translate the evidence, and what are the challenges in translating the evidence through communications for public acceptance, right? So I will, in the interest of time, I'll just do a bullet point version of what I wanted to say, and I'm happy to answer any questions and engage in a colloquy later at the end of the talks. So in our view, there are 3 communication challenges that deter from this, the evidence from being translated and accepted. So in addition to the other barriers I mentioned earlier. So one is this, it's a very complex information ecosystem. So we have obviously mass media such as television, radio, newspapers, which talk about health, including some recent articles questioning, for example, HPV vaccination in terms of priorities and importance and even safety. But also, as has been alluded to, I think social media have a big role with 500 million social media users in India who spend more than a couple of hours a day on an average. And with the algorithms and different kinds of platforms, each person has his or her own information repertoire, as we say. So what you see in your feed is very different from what I see in my feed. And that provides a challenge in terms of what we say and how we say it. But in addition to social media, there are and questions about the efficacy of the effectiveness of these kinds of information environments. There are social networks, people around us, families, friends, colleagues, neighbors, all of them have opinions about these things, about medicine, about health. There is folklore, and so it's a very complex system that really warrants some thought in how we want to communicate, overcoming that complex information ecosystem. The second is what we call as communication inequalities. We have published quite a bit in our lab on these issues. There are two dimensions to these inequalities. One is, in terms of access to, communication services. Despite the penetration of, say, smartphone, it's still even the cheapest smartphone is about as costly as 40% of an average income in India, and they're not that easy. Though data plans are cheap, but access to reliable information is questionable. The reason you have misinformation and wrong information, or rumors as some have called it, is because there is an absence of accurate information. What I mean by that is sufficient access that is broad and deep. And that can, that's a real, particularly among social groups. If you are highly educated, higher income or medium income, you have better access to information services compared to what we call as a lower socioeconomic status. And the third challenge is the anti-vaccine movement or information that is incorrect by even people with good intentions. And so how does that happen? I think, what happens in questioning, and we have studied this, what happens in questioning vaccination, particularly around HPV vaccination, but other kinds of vaccines too. Number one of the strategies they use, invoking scientific authority or expertise. People call themselves doctors or scientists, but they're actually using what I call as scientism, not scientific language. They use throw in technical terms, technical jargon such as RNA, DNA, to engender doubts and fears among people. And particularly around rhetorical strategies, there are a lot of questions on adverse reactions, and how those adverse reactions could lead to questions about safety or efficacy. You don't have to say it's bad vaccine as much as you can just suggest doubts, especially if people are on the fence. Doubts can be pretty potent in deterring them from acting. And then other people have questioned, is it necessary? Is it an unneeded medical intervention compared to all other priorities we have in India, right? And then, of course, as you will see, there are conspiracy theories propagating myths about, it has a live virus or it's a DNA, particularly targeting vulnerability of parents, who are making decisions about their children. And of course, they question authority, who is making money out of it? What are they hiding from it, right? So these are typical strategies that are used to really cast seeds of doubt and deter the vaccine from penetrating, right? But the hope is not lost. I'll provide just 3 solutions, based on evidence. One is bridging those inequalities. It's really critical to ensure that the right information, accurate information, is translated and is available across the spectrum and not to limited audiences. I think that's important to do that. And that's being done, as we just heard. Second, we should not let myths go unchallenged. But, and as the speaker prior to me has said, we should not let it go unchallenged, but we should draw on communication signs, on how to challenge those myths. That there is fairly good evidence on what message strategies we should use, what message formats we should use to really address those myths, address those rumors. For example, we just can't repeat them because they can still, reinforce certain ideas, bad ideas in people's minds. And developing credible sources of information and creating the right information environment is very critical. For example, physicians and community health workers are one group who are heavily trusted. There is very good evidence that physician recommendation, particularly parents are expecting unambiguous recommendations from physicians. Physicians have been hesitant, in the past, but wherever physicians or community health workers are certain in their recommendations, that has an impact on parental decision-making in vaccination. So, and tackling the information ecosystem is very critical in this, I think. So, and the last point that has been said earlier is stakeholder engagement. We really have to make it a citizen movement, and we have to go beyond authorities, as we say, to really have a mass mobilization, including the stakeholders, as a part of the conversation, and that has, that could be potentially efficacious. So I went through this very quickly, in the interest of time, but I'm happy to elaborate or answer any questions later. Thank you, Ms. Gupta.
Thank you so much, Dr. Viswanath. Thank you. All very important and very relevant points for us. We know how easy it is for information to for mis and disinformation to spread. So these are very important points. And taking from that, I would like to invite Dr. Anu Agrawal, Vice President, Global Cancer Support, American Cancer Society, to talk about strengthening the medical community in India. This is what Dr. Viswanath was just talking about, that they are the most credible source of information. Dr. Anu, we leave it to you to take this forward.
Thanks, Mridhu. So happy to be here. Really an honor to be part of this panel and to see so many participants. Wonderful job setting it up. Congratulations. So yeah, that was a wonderful segue by both Emily as well as Dr. Viswanath into our presentation regarding some of the work we've done collaboratively in India. And I think just to emphasize the points that both of them made is that it's really vital for us to work together to dispel myths. HPV vaccination should be like other vaccines, but unfortunately it's very special, and there's a lots of rumors, and we face this challenge still in the United States. But really having a very clear message about this being a cancer prevention vaccine is really critical, and working collaboratively is really vital to ensure that we have a very uniform message surrounding this very, very important issue. It's really a singular, unique opportunity to really globally eliminate HPV-related cancers, and India is a huge opportunity for that. So I wanted to just speak briefly about some of the work that we've done collaboratively with multiple organizations globally, but also specifically in India, many of them who are listed here and in the slides to follow. And this is work really done by our prevention and screening team, which is led by Minu Anand, who's on the webinar as well. So we've really focused on behavior change interventions. So as Dr. Viswanath said, there are data now that really support how messaging needs to be provided to ensure behavior change. And we work globally through convening and partnerships to ensure this messaging regarding this being a cancer prevention vaccine, both through our Cervical Cancer for Action for Elimination network, as well as preventing global HPV cancers. So the research that we've done has really been looking at how behavioral barriers across the global south, so our work has been in Colombia, Kenya, and largely in India, how behavioral barriers have limited uptake of HPV vaccination and how we can better engage healthcare providers as well as parents, and then co-designing solutions for this. And we're now moved from the research stage to really taking action stage and working with partners. And I think, as mentioned by Emily, really focusing on working at the subnational level is really key to ensure the messaging occurs correctly. And given the scope of India, the vaccine rollout really has to be occurring at the state and below level to be successful. So we've really focused also, as we've all learned in the last decades, really clearly important to focus on working with local cancer leadership, local leaders. Co-creating development, implementation, and evaluation of solutions is really key. We really want to be a technical partner and not drive this work in India and other global locations. And then working with local district level to really prioritize and sustain efforts of increasing cancer prevention services, especially HPV vaccination. So as Dr. Viswanath said, and I wanted to emphasize again, the recommendation of healthcare providers is key. And we see this issue still in the United States too, is if there's not a clear message from healthcare providers, this will prevent families from uptaking the vaccine. So healthcare providers are a key credible source of information, and it's very, very key that we have a singular message on how important it is to have HPV vaccination. So just including a quote here, but we have also created materials specifically for healthcare providers, understanding the barriers to physician recommendations. And many of the themes that we found are global themes in all settings, high-income country settings like the United States, and in the global South settings where we have worked. And then we've designed, again, co-designed impactful interventions to support healthcare providers and having a singular message about this being a cancer prevention vaccine. So we've really worked in India in two methods. One is working with medical societies, which will be a good segue to the next talk, and also working with many CSOs, which have been listed in the slides here. And I'm not going to talk a lot about this because it'll be talked about specifically in the next slide, but really working with medical societies to, again, increase education by providers who will be talking to families, both pediatricians as well as OB/GYN physicians, but there needs to be increased reach for GPs as well in India, which are going to be driving a lot of this work, as well as community health providers. And so again, our job is to provide technical support and assistance as part of the Global HPV Cancer-Free Network, and then working with multiple organizations like Cancer Foundation of India. So again, we've really been able to move over the last several years from implementation science research to interventions now that are growing from multiple different places and multiple different organizations throughout India, and just highlighting many of the action guides that we've co-created, which again really are important and available to ensure that we're all providing a singular and same messaging around HPV vaccination. So again, a lot of this work is going to have to occur at the subnational level to be successful. And so we've worked with other organizations like CAPID to work at the district level, again, to provide buy-in and education to the healthcare workers that are at this level. And again, distilling rumors at all levels of the system within India are really going to be key to having a successful rollout. And again, this work has gone from pilot to really implementation and starting to expand beyond the initial districts that it was started in. So again, we have all of these materials that are specific for India that have been co-created by our partners in India. These are available, and I hope that you all take a look at these. There's a QR code. I think that'll answer a lot of the questions that are coming up in the chat and the QA too that are being answered very well. But if you all want further information, please take a look at these. These are all available and really help with ensuring that we have a singular message at all levels within the system. Thank you so much. It was really a pleasure to be part of this panel and to present the work that's been done by our team here in India and other places. And again, working collaboratively will really be key ongoing to ensure that we have a successful rollout. We've seen in many places the initial very successful rollout, and then lots of missed messages and decrease in vaccination. So it's going to be really key to have a sustained approach to ensure continued increased vaccination over time. Thank you so much.
Thank you, Dr. Anu. Thank you. And it's true, ACS's work in India has been hugely impactful, lots of resource material that has come from there. And I think there is the link to the resources has also been put on the chat. And if anybody wants to, you can just pick it up from the chat and use it. And for all those who've joined us a little later, I want to repeat, please put your questions in the Q&A box, because the chat gets really crowded. It's very difficult for us to find your questions. We might just lose them. So pick them up and put them into the question and answer box, and we will try and answer all your questions there, please. Thank you. Thank you, Dr. Anu. As Dr. Anu says, we will take forward the medical society communication and what they are doing to build this trust and faith in the vaccination. And Dr. Priya Ganeshkumar, Oncology Chair, FOGSI India, will talk to us about it. I think we have a video for her. Dr. Arpan, would you be sharing the video? Yes, thank you.
Works.
Dr. Arpan, there's no sound again. Can we look at sharing this with the sound?
Let's move on to Dr. Pramesh then, Ritu.
Should we move on? Should we give it another
I think
shot?
so.
Okay. Right, so we might come back to this later. And I then would like to invite Dr. Pramesh. He's representing the National Cancer Grid. Dr. Pramesh is Director, Tata Memorial Hospital. And he will be speaking about the National Cancer Grid in India. Dr. Pramesh, are you here? We can't hear you.
He's on mute.
Dr. Pramesh, can't hear you.
Yeah.
Yes, yes.
So do I have the right presentation on?
Yes, it says the National Cancer Grid, eliminating disparities in cancer care. Yes.
Great, thank you. First of all, thank you for the opportunity to be part of this very important meeting. I think we've heard a lot about cervical cancer elimination over the last few minutes. And what I'm going to tell you is something that's very different about what we are trying to do. And that is on implementing some of the work that we are doing within the National Cancer Grid. And for those of you who are not aware of what the National Cancer Grid is about, what brought this about was this heat map of close to 75,000 patients who visited the Tata Memorial Hospital over a 6-month period. And as you can see, the density of patients in and around Mumbai is understandable. But what was very disturbing to us was the large number of patients who came to us from long distances, often traveling 12 to 18 hours just to access very basic quality care. And therefore, we thought there was something that needed to be done about this. And we invited the then 29 regional cancer center directors to be part of this meeting to brainstorm on how we could avoid patients having to travel thousands of kilometers just to access basic high quality evidence-based care. And over the last 12 years since the Cancer Grid was created, we've grown substantially. And today we cover most of the length and breadth of the country, as you can see from this map. And we are currently at close to over 360 cancer centers. We've expanded the membership to research institutions, patient groups, professional societies, and charities across the country. And the only reason I share this is because much of what we do could lend itself very well to this effort at cervical cancer elimination. And I would urge you to use this platform to implement and on the ground create and develop many of the interventions that you've spoken about over the last hour or so. And again, the reason I say this is because between these 360 plus centers, we treat more than 850,000 new patients with cancer every year, which is roughly 60% of all of India's cancer burden. So the ability for scaling up on any intervention that's introduced into the cancer grid is fairly substantial. The 4 pillars on which the cancer grid was created was first and most importantly to have uniform standards of cancer care, to develop trained human resource, capacity building to meet the unmet need in human resource to treat cancer, to be a ready platform for collaborative, multicentric, preferably multidisciplinary cancer research, and finally, increasingly over the last 3 or 4 years, to frame national cancer policy, which is especially germane to the discussion that we are currently having. So many of the initiatives that I'm going to describe now would lend themselves to cervical cancer implementation. So we have resource stratified evidence-based treatment guidelines. So this is something that we should work on. We are in the process of revising the evidence-based guidelines, and this would be a great opportunity to introduce the scope of the 90-70-90 goals that the WHO has within the NCG guidelines. We also need to look at cost effectiveness, and I think we've heard several speakers earlier speak about the high cost of the cervical cancer vaccine. So we have a robust health technology assessment program, an adaptive HTA process, which we developed in collaboration with the Center for Global Development. And the process and methods guide is again available for anyone who wants to use this. And if you want to do this for cervical cancer vaccination or screening, this is something that we could certainly consider. Pathology and cytology and molecular pathology quality assurance is another activity that the National Cancer Grid does. And given the opinions that we've heard about cervical cancer screening, quality control in cervical cancer screening is something that we could potentially partner with this group on. In general, quality assurance is not something that is highly emphasized in healthcare providers in India. So we do have quality assurance and a quality improvement training program, which is a blended learning program. We've been doing this over the last 6 years. Over 100 teams have been trained on this. And this would again be an opportunity for us to improve the quality of the delivery of cervical cancer elimination programs that we are currently doing. Again, to overcome the problems that we heard about communication and dissemination of information, we have a massive open online courses, which goes under the NCG education portal. Another opportunity for us to use the platform that we've created within the NCG to enable increased access to continuing medical education. We heard a lot about quality control and how we needed to improve the way we educate providers and healthcare workers. So we've come out with this fairly innovative traveling school of pathology. Again, a model that could be replicated for the cervical cancer elimination program. So instead of expecting people from remote areas to come to cities like Mumbai, Delhi, or Chennai for continuing medical education, what we do is to flip the system around and send a group of experts from within the cancer grid across remote areas to ensure that continuing medical education is available at the doorsteps of these professionals. We've learned a lot from group negotiation for cancer drugs and an opportunity for negotiating for products such as reagents and vaccines for cervical cancer elimination. So what we do is to aggregate demand from multiple centers, we pool their volumes, and go through a central tendering and negotiation process, completely in compliance with the Government of India norms. However, the final contracts are signed between the pharmaceutical companies and the centers. And the kind of discounts that we've been able to achieve have been quite astounding, ranging anywhere from a minimum of 23% to a 99% savings on MRP with an average saving of 85%. So effectively what this means is that by assuring volumes to pharmaceutical companies, you're able to reduce the cost of a 100 rupee medicine to just 15 rupees, dramatically reducing the costs of care overall. And for those of you who are interested, there's this publication in the Bulletin of the World Health Organization, which describes this in more detail. The final bit I want to talk about is that this is also a great opportunity for research. We did this brainstorming exercise with several global leaders on cancer research. trying to identify priorities for cancer research in low and middle income countries. And I just want to mention these 5 key priorities that we identified in this paper. And every single element of what we had identified as priorities would probably be applicable to this effort that we are doing. The first, to reduce burden of patients presenting with advanced disease, the 90-70-90 principle. To improve access, affordability, and outcomes in cancer care via solution-oriented research, country-level health economic assessment of interventions and HTA, quality improvement and implementation research, and to leverage technology to improve cancer control supported by robust evidence. And every single one of these key priorities would align very well with the efforts that this group is currently doing with cervical cancer elimination. So I'll stop with that, and happy to take any questions during the Q&A later on. Thank you very much for your attention.
Thank you, Dr. Pramesh. Thank you. Some wonderful resource material being shared here today. You can all access it. Taking forward this multi-stakeholder collaboration for cervical cancer elimination, I am inviting Dr. Rajshankar Ghosh. Dr. Ghosh wears multiple hats, but today he's representing the Cervical Cancer Elimination Consortium India.
Thank you.
Over to you, Dr. Ghosh.
Can you hear me and can you see the screen?
Yes, yes, we
Yeah.
can hear you and
Wonderful.
see the screen.
So greetings to everyone. I represent the Cervical Cancer Elimination Consortium India that was formed about 8 months back. And I'm going to speak about a strategic approach to 100 cervical cancer Mukt districts in India that has been proposed to the Ministry of Health and Family Welfare. And we are progressing with the Ministry of Health and Family Welfare in ensuring as to how we implement this. The genesis of this was that the government of India announced a budget allocation for cervical cancer vaccination in India as a midterm budget. The second is that India currently manufactures indigenous cervical cancer vaccine with assurance of uninterrupted supply of the vaccine for India's universal immunization program. The third is that the Quad country launch Cancer Moonshot Initiative to reduce the burden of cancer in the Indo-Pacific. Our Honorable Prime Minister, who led the cancer cervical elimination conversation very recently in USA. The Global HPV Consortium, a model has been developed, which is working with multiple countries. And in that model, we set it up in India. And finally, with the new government, there was a launch of the 100 days priority agenda, which had significant focus on women and child health. And therefore, we took advantage of this in order to propose to the government of India the 100 cervical cancer Mukt district. The way that, we are structuring this conversation with the government is that we would like to discuss that this is in continuum of a policy decision where evidence-based advocacy with policymakers and influencers on the primary, secondary, and the tertiary evidences. The second is that the policy needs to be translated into programs. What we are proposing is an integrated strategy for cervical cancer elimination, which we call the SAFE strategy, which stands for screening, access to treatment, vaccination, and empowering communities with education. And we said that, this could be implemented in 100 cervical cancer districts, 100 districts as for the cervical cancer Mukt program, and then the scale up for this could be done by the states and the government. The practices that we are talking about is around the documentation and dissemination of the best practices through the various partners of the consortium that are being done in the states and have been conducted in states. We are also looking at various low and middle income countries and some of the best practices. We have made a compendium of that and shared with the government. And finally, we are looking at a wide variety of partners, including the public sector partners, academia, private sector, and we will come to this later. The way that also we have proposed this is in terms of health system strengthening approach and not just in terms of a vaccination or a diagnostic intervention approach. The way that we are speaking about it is our 6I approach, which we are talking about an integrated strategy the integrated strategy. One is across the SAVE approach that we talked about. The second is integration into the larger national program for prevention and control of cancer, diabetes, cardiovascular diseases, and stroke. And the third is the integration between the public, private, and the non-governmental agencies who are working towards cervical cancer elimination. All of these different kinds of partners need to come together in order to make this a successful program in the 100 districts identified. The second is that we are looking at the impact assessment. We are trying to kind of work with the government to understand the various kinds of digital interventions that the government has currently introduced, including the UN program for the routine immunization and other kinds of digital interventions that the government is introducing in order to measure the progress of cervical cancer elimination through the 90-70-90 progress indicators of WHO. The third is that we are looking at various kinds of innovations that our partners are working in the districts, at the states, and also, as I said, from the various low and middle income countries to be applied into India's health systems. The fourth is that we are strongly advocating with the government for the investment through the program implementation plan, which is the PIP budget of NHM, to be diverted to some of these activities. One of the important considerations is that cervical cancer disproportionately affects the vulnerable populations, and we are focusing on giving the message of a vulnerable population focused programmatic approach in these 100 cervical cancer mukt districts that the states will choose. And finally, we are very interested in terms of institutionalization of the learnings from the program through documentation and the dissemination of this program. And as I will speak later on, we have our secretariat of this consortium at IIT Delhi, and IIT Delhi will be the institution where we are going to document all the learnings that we have from the various districts. The various kinds of partners that we have are the implementing partners, various implementing partners working at the state and the district level. We have academic institutions which are contributing through their research and various kinds of academic learnings. We have a large number of subject matter experts who are contributing with their subject expertise. And finally, we have also included our media persons, veterans, and also actively engaged in the media who are guiding the communication principles for this strategy. At the district level, there are various kinds of activities that are happening, particularly in Karnataka, in Chennai, in Tamil Nadu, in Andhra Pradesh, and Telangana. There are various state partners who are conducting these programs, and we are documenting those programs to be presented to the Government of India for the lessons that we are learning from these programs. There are various partners, and I will not name all of them here, but these are the partners, and as we described before, that they come from various kinds of domains. And the secretariat for this is at IIT Delhi, and we have every month meetings of the various partners to learn about how they are progressing in the various kinds of activities that they are doing and the lessons that we are learning. Out of this, what we have done is we have developed a white paper, and also we have developed an action plan on the request of the government that we convert the white paper into an action plan for 100 cervical cancer mukt districts. These are freely available. If you would like to have a look at the white paper or the action plan, you just have to reach out to us and we will be able to provide you with all the necessary information. There are various individuals who are scientists and who are experts in the domain of cancer and in the domain of women's health, in domain of health system strengthening and immunization, who are guiding the consortium towards the activities that we are planning to do. And finally, we would like to invite you to join the consortium and be a part of this larger kind of strategic approach that we would like to have towards the 100 cervical cancer Mukt district. One thing that I would like to make clear is that we are not identifying the districts. The districts will be identified by the states, and we are going to work with the national government to identify the districts by the states, and we will provide support in 4 areas. One is around the designing of the plan for the integrated approach to cervical cancer elimination. The second is around the training programs through our various partners. The third is development of tools, digital tools for measurement and evaluation through our IIT platform. And finally, we will be able to document and disseminate the information to a larger forum. Thank you.
Thank you, Dr. Ghosh. Thank you. And now we move to the last panelist, Ms. Sutapa Biswas. She is the BCC convener and co-founder of Cancer Foundation of India. BCC is the latest kid on the block. It's a new coalition. It's a new network of NGOs. And Sutapa, we leave it to you to give us more information on that.
Yes, and when you come to as a last runner of the relay race to time, one has to run the fastest. So I believe that that's what I have to do. But thank you, everyone. All the speakers, they make it easy of how we justify why we have the Beat Cervical Cancer Network. It seems to be a natural progression when you start thinking of what needs to be done for the rollout of the HPV vaccination. So it is collaboration. It is about sending the messages right. So that's exactly why the BCC was created. We all had come together sometime around May of 2024 and supported by the American Cancer Society and Cancer Research UK. The whole idea for us was to have Indian NGOs planning for India and with focus on HPV vaccination to start with, along with screening. And this network, it's a loose network of NGOs that is initiated, and we'll have more and more NGOs joining in eventually. But the idea is on communication, that how do we have evidence-based messaging that goes to everyone on HPV vaccination? It's a huge task, easier said than done, but it needs careful planning from our end to make sure that it goes to every person here who will take up the vaccination eventually. And in this particular network, now we have started with 7 of our founding members, and they are all here with us today as well. We have the Indian Cancer Society, the Coimbatore Cancer Foundation, Prayas Pune, Hridaya Delhi, CAPIT in Gurgaon, MPVH Indore, and the Cancer Foundation of India. We're based in Kolkata. There are 4 key objectives that we have. As I said, the overarching theme, of course, is communication. But the main thing that we have in mind is that the narrative of HPV vaccination has to be a little more towards cancer prevention. Currently, it is more on immunization. But if you're able to understand that it's a cancer prevention vaccine, the uptake would be higher because there'll be a tangible reason for the parents to come forward and take the vaccine. And accordingly, we intend to align the NGOs. There aren't too many cancer prevention NGOs. It is going to be both cancer and non-cancer NGOs who will be included in this network to take part and take forward also the consistent messaging that we have when the HPV vaccine is rolled out. In order to do that, we intend to onboard NGOs through different programs and make sure that we have leaders created in different parts of the country. And as for the screening, we'll focus primarily on advocating for the high-performance HPV test. The reframing the narrative is one of the biggest challenges that we have now, because what we hear from the government that the focus is going to be to roll out the vaccination through the immunization arm. But we feel that, the cancer group needs to be included in it. They need to sit on the table and bring forth the reason of why one would want to vaccinate for HPV is to control HPV cervical cancer. And that should be the primary focus, and which is a huge challenge for us, but we definitely would want to. And that's the reason why the cancer NGOs have come together to initiate this network, which is BCC. Aligning the NGOs, of course, as I said, there aren't too many cancer NGOs that are working in this space, because when we were looking around, we found that many are working in cancer screening, cervical cancer screening, but not many in cancer prevention, but in HPV vaccination, but there are many in cancer prevention. We can bring them together and align them. And there could be a lot of groups working across the country, which we are not aware of. Many I find are there today in the audience. So we would like that you share the work that you are doing so that we are able to identify the groups and could include them into the network. The whole idea is that we are able to cover the country well, which is north, south, east, west, central, and the northeast. So we'll have to keep in mind that there are going to be cancer and non-cancer NGOs who will have to be brought together. We would intend to have some of the NGOs taking up leading roles in the different states so that, as and when we have the vaccination rollout, there would be there will be need for, a lot of NGOs to give out expert opinion also, either to the media, as Professor Fish said, that, the media is going to take the message forward. So we need a lot of local and regional groups coming up. And also remember that, we have the science always in place, but what is important is how the science messages are taken to the right community. And India is extremely challenging to work in because of the social differences, because of the language. It's very, very tricky to work. So we have to include different regions and states to come on a same platform. That is the primary objective. And for the cervical cancer screening, what BCC intends to do is advocate for cervical cancer screening through the high performance test, the HPV test. And there are other groups also working. So we would probably be working with them and make that voice stronger by coming together. We currently have a newsletter, which we started 4 months ago, so which is circulated to a lot of us. So if there's any who intend to have the newsletter, please let us know. We'll, of course, send it across to you. And we invite Indian NGOs to join the BCC network. And it is a great experience for us to start off something like this. And I would like to thank the American Cancer Society and Cancer Research UK for the support. Thank you, Mridu.
Thank you, Shutapa. You really did race through that presentation so that we can be done on time. Yes, it's 8:20 now. So just quickly through the questions, if I may, I can see 44 questions have been answered. That was a lot of work being done at the back. But there are still questions for specific panelists. Dr. Pramesh, there is a question for you. It says we have a consortium in Mysore and need to upgrade our pathology skills. How do we access the traveling school of pathology? We are also planning on scanning slides and making a learning library with case studies, with clinical history, colonoscopy images, and pathology slides. Would love to have the NCG input. Would you like to answer that?
Yes, all that you need to do is for you to become a member of the National Cancer Grid. There are 2 or 3 ways that we improve overall pathology quality nationally. One of them is the Quality Assurance Program, the EQAS program, which is available free for all member organizations. It's a web-based program where quality of pathology, grossing, reporting, including immunohistochemistry and molecular pathology can be assured. So that's one way quality in pathology can be improved. The second aspect is the traveling schools, where we run a roadshow where experts within the National Cancer Grid go across multiple cities, training individuals, diagnosing cancers, typically pathologists and surgeons, with best practices of grossing as well as reporting, and including a synoptic reporting format, which ensures that pathology reports are complete. So you can reach out to us on the NCG email, and we'll be happy to help with that. I'll put the NCG email on the chat.
Thank you, Dr. Pramesh. I think this one is for you, Shutapa. It says, Beat Cancer. We are a consortium of 3 medical colleges and an NGO in Mysore. We offer HPV testing at cost. How do we align and join your movement?
You can just send an email. I just sent it on the chat. That you sent an email to us with a request. We'll reach out to you.
There's one question here that I don't get. What about patients in menopausal age group? Are you asking, Anita, are you asking for the vaccination? What is that? For screening? I didn't get that question. I'm sorry. Any other questions?
Chat.
I think there's the other questions have been. Oh, there are questions on the chat, which is what I was saying, that now we'll have to dish them out, right? Okay.
I think most of the questions on the chat have been answered, or they have transferred the questions onto the Q&A.
Yes, that's what I was saying. Just let's put them on the Q&A. I think they have been. There are 47 questions answered on the Q&A, which is like a lot of work done.
Yeah.
If there are any questions, please put them on the Q&A and can panel member discuss evidence of cost effectiveness between vaccinations and early screening. Would somebody want to take that?
I can answer that briefly.
Yes, Dr. Lata.
In either or situation. And we know from modeling studies that what really works is a combination of vaccination and screening. If we had to do just vaccination, it would take us many, many years to reach the global elimination of cervical cancer. So what is actually recommended as per the WHO, and as you can see from the pillars, is a high coverage of HPV vaccination. We are looking at 90%. And at least 70% of women screened. So it does go hand in hand. It cannot be either or.
Thank you, Dr. Lata. There's a question here, and I think that it would be good to answer that. People after awareness are coming at 45 years age for HPV vaccine. What is the suggestion? What is the recommendation here?
I mean, I think from a public health perspective, it makes sense to vaccinate till 26. And anybody who comes for vaccination after 26 years, I think there has to be an emphasis on offering them screening. And it has to be a one-to-one decision as to whether vaccination will be of help.
So I think, thank you, Dr. Lata. I think that answers the regarding vaccination in menopausal age. I guess that answers that as well. Lata ma'am, this is for you, Dr. Lata. Which schedule should be preferred, one by the DCGI or single dose? A single dose is still not approved by DCGI.
So the DCGI generally makes a recommendation only if the manufacturers ask for it. There is more than enough clinical and scientific evidence to support the single dose. And I think that is what the current recommendation has to be. 9 to 20 years single dose is what is recommended at present.
Thank you. There's a question to the panel. What does this panel see as the next, where did that go? A next key step to get HPV vaccine in the UIP? Who would like to take that? Emily, would you like to see what would be the next key step to get the HPV vaccine in the UIP?
Well, I think there are a few steps, and the key to have a successful launch is to align availability of vaccine supply with the ability to deliver the vaccine and the mobilization in the community. So I think when we have confirmation about when those vaccines would be available, then we need to work backwards to say, when will we start our communications? How will we distribute them? How are we engaging the stakeholders that would be involved in delivering the vaccines with appropriate training, information, materials, all of that. So it's about setting up that timeline aligned with when the vaccines will be available.
Makes sense. Thank you. And this is an interesting one. As a doctor, if I use single dose in India, will I be medico-legally protected if challenged by parents? Anybody?
Because we don't have the licenses yet for Cervavac, definitely. But I think we'll have to wait a little while.
It is off-label, and that's something that we've heard a lot of people talk about that. Dr. Lata, are they medico-legally protected?
Not at all, because the SAGE recommendations very clearly say, and as Dr. Devasena also mentioned, there's a very recent publication that shows that the single dose is efficacious. So that is the current recommendation. So I do not think, or I do not foresee any medical legal problems with that recommendation.
Thank you.
I'd like to come in on that point. I think the WHO recommendation is a global recommendation, so there is nothing illegal in administering a single-dose HPV vaccination. And given that most of these HPV vaccinations are going to be in adolescent girls, and if the parents are going to bring them in for vaccination, they wouldn't really be surprised that their child is getting a single dose.
Yeah, and if I may add, the country has been using off-label vaccines for polio also. IPV is also an off-label use, interdouble vaccination is also off-label. So I don't see any harm in using the SAGE recommendation, and the country's ITAG, the National Technical Advisory Group of the country, that can take a call and advise the ministry as appropriate.
Thank you, Dr. Bhuta, for that. The NITAG in India has already, recommended to the government about using single dose for the ones which SAGE has recommended for. But for the domestic manufacturer, the NITAG has said that to continue with the 2 doses, and that is all available in the public information at the Press Information Bureau website.
Thank you, panelists. I think this one is for you, Dr. Ghosh. I know you have responded, you had spoken about it in your presentation, but they say 100 districts are selected for cervical cancer Mukt. What were the criteria for selecting those 100 districts? If you would like to reiterate.
That we are not, so I'm just saying that we are not getting any criteria for that. We are leaving it to the states to identify the districts. What we have said is that the states should identify the districts. The national government should provide the funding to the states through the NHM and the PIP funding, and we will provide the 4 supports that I talked about: the design of the plan, the monitoring, the training, and the documentation of the program for the states to scale it up in other districts. So we are not providing any kind of, and the government has also not asked us to provide any criteria for selection of districts. If the districts asks us, we will work on that.
Thank you.
Mridu, I would have a question for Professor Vish.
Yes.
While we answer the questions, Lata, if you can answer some of the questions on dosages, what should we start off in terms of communication? What should be the first thing that we should focus on now that we are thinking that the rollout would happen maybe, next year, second half? So what is it that one thing you think we should focus on, if it's that?
Yeah, thank you. I mean, it's difficult to say it's one thing, but in the language of public health emergency preparedness, right? We talk about preparedness, right? Being ready for it. We have enough evidence. I think Dr. Agrawal talked about it, Ms. Kobayashi talked about it, and others have done work in this area, including yourself, Sutapa. We know what's going to happen, right, when this vaccine is being introduced. We have fairly good evidence what's going to happen from a communication perspective, and we have fairly good evidence that what can be done to counter that, right? So the preparedness part of it is very critical. So I think one of the things is to make sure that more accurate information is more broadly and widely available. See, hopefully in the next couple of weeks, the national academies in the US will come out with a report on science misinformation, which I'm chairing as a committee. And I hope it's going to be released in the next couple of weeks. And what are we learning from all the studies we have been looking at, right? You have misinformation, you have rumors, when there is a lack of accurate information that is easily available, right? So I think the first thing to do is have that kind of infrastructure. The National Cancer Grid is an amazing exemplar of, we are prepared in the healthcare or the cancer care setting. How can we prepare ourselves similarly in the realm of communications, right? Cancer communications, having that kind of an infrastructure. Number one, and being ready for it, right? Make it widely available. Number two, dissemination, right? I think the partnership that has been alluded to by so many speakers here is very critical. It's pretty impressive when you hear all the partners who are working at the ground level. I think that's where we want to focus on, and how do we really work together, mobilize these different groups and ensure that we are on similar pages when it comes to this kind of a dissemination, I think, and then preparing our healthcare workers, frontline workers, and our physicians. They are so critical. Somebody said, healthcare worker or a doctor is like a god. Certainly in our language, we call it trust in authority. And I think, it's extremely important to make sure that they are ready for it and they're prepared for it. So.
Thank you.
Mridu, I just wanted to have a quick question to Dr. Anu. May I?
Yes, please. It's 8:30 though, so
yes,
I think
that's just a quick one.
Yes,
just
a quick question. Yes, and then.
So, yeah, thanks, Dr. Anu. It was very good presentation. I just wanted to know the plan for training the general practitioners who are, say MBBS or BHMS, now that you have actually done very good job with the pediatricians and, the gynecologists across the country.
Yeah, thanks, Dr. Vandana. That's a key point because most patients are going to be seeing GPs, and so we have to try to impacts the GP network. So we are trying to determine what's the best way. So that's definitely something that we could work on together. I think that we've thought about, what societies are GPs part of in India. But yeah, I think that's something we'd really like to tackle. I think to the prior question, really, the key message is really that providers are very, very concrete about the importance of HPV vaccination to prevent HPV-related cancers, especially cervical cancer. And we've seen this problem in the US too, is when the providers say very clearly, you should vaccinate your child, parents will do it. But when they are not convinced themselves, that becomes the problem. So that's really the key message, is convincing the providers, because they're going to be the frontline workers who are getting families to vaccinate.
Thank you. Thank you. So it's past 8:30. There are a lot of questions, about 16 questions. We will try and answer them, have the panel answer it and share it with you. If you want to see the recording or want to know more, it'll be available on the BCC LinkedIn page, the Beat Cervical Cancer LinkedIn page. Over the next few days, you can watch the recording. And now I'd like to hand over to Dr. Lata Balasubramaniam. Dr. Lata is Secretary, AOJ in India, and she is the founder of the Coimbatore Cancer Foundation. Dr. Lata, if you would wrap this up for us, please.
Thank you.
Thank you.
We've had such an eminent panel and a wealth of information that has come in, almost a 360 degree of what needs to be done for cervical cancer prevention, both screening and vaccination. I mean, very pertinent points about, the difficulties of having the 90% vaccination that the WHO mandates us to do with supply, and more importantly in India is affordability. I mean, certain points really stood out. One was Dr. Devasena's presentation. I mean, showing us that single vaccine is absolutely efficacious, and this is something that we have to be working towards. One of the points Dr. Emily brought out was the sustained vaccination year after year. And I think this is absolutely important. And this was one of the things that came up when we were discussing about the rollout of HPV vaccine in India. Do we have a stockpile of vaccines so that once we get the vaccine program started, then it will run on? And of course, the importance of behavioral change. A key point when we had the NCG meeting recently was the importance of health promotion and wellness and health promotion. And for me, one of the key takeaway points was to be patient. We had excellent panelists in the NCG meeting. And one of the key takeaway points that for anything important to happen, it takes a period of about 10 to 15 years. So that is a very important message for all of us who are absolutely impatient in getting this up and running. So we just have to keep doing our bit, keep plugging, and ensure that this happens. And the other important point was about health systems thinking. And this is what a few of our panelists spoke about as well. We just cannot change one part of the health system. It has to be a health systems thinking. And this is what Patty Gravitt's work in Peru has shown as well. And to Dr. Ghosh, I have one question. Yes, it makes sense to integrate with the other NCDs, public-private partnerships. Could we throw insurance into this mix as well? Would that make it more viable? So lots
Absolutely.
to think about. And, it'd be really good to get all this working together. And one of the things that we decided at the NCG meeting would be to look at the IEC that is available pan-India. There is no point reinventing the wheel. And there are so many groups working in silos, working both in vaccination and screening. And from the NCG, we will be reaching out to everyone so that at least we have a dossier of what is happening in the country, what is actually happening on the ground level. And that, I'm sure, will be a great learning for all of us. So thank you very, very much for joining us this evening. It has been a wonderful hour and a half. And thank you all. And yes, the recording of the webinar will be available. So tap up to...
Yes, from the 17th.
Yes.
Release it on the 17th.
Yeah. So that resource will be available for us if you want to listen to any of the lectures. And the emails are out there, both the NCG and the Beat Cancer. So do feel free to reach out to us. We are here to help you. And hopefully this will be the first step in bringing all our organizations together. So thank you all and have a very good evening.
Thank you so much. Thank you. Thank you to the tech team also.
Thank you, everyone. Thank you to all the panelists. Thank you so much, everybody.
Thank you very much.
Thank you, everyone. Bye-bye.
Thank you. Bye.
Bye-bye.
Thank
Bye-bye.
you.
Thanks,
Thank you.
everyone. Bye.